All right, so today I'm going to be intubating this patient. Before we start, I'm going to go over some information about intubation. So indications for intubation would be unconscious patient, patient without a gag reflex, GCS less than 8, a patient in cardiac or respiratory arrest, patient not able to maintain their own airway. And some contraindications would be if they're conscious, if they've got a gag reflex, and then like major facial trauma might be a problem too you'll run into. Some special considerations would be if you have a pediatric patient, you'll have to pad the shoulders due to the size of their head compared to the rest of their body. Some complications you could run into would be if the tube goes into the esophagus instead of the trachea. In that case, you'll have to pull it back and then try to get it back into the trachea. That, or if you go main stem, which is going into one bronchi versus the other, you'll have to pull back a little bit so that you're getting air into both lungs. And then if there's any aspiration or blood or any mucus or anything, saliva or anything like that in the tube, you'll want to have suction ready to suction the airway so that it's a good airway. So to start out with, I would have a partner. They would be using a BVM attached to high flow O2, and they would be pre-oxygenating the patient as I prepare my equipment. So I'd select the appropriate tube size. I would check the balloon, make sure it holds air. I would leave the syringe attached for now. I would also have a tube size above, a tube size below, just in case the tube size I grabbed doesn't work. I also have backup airways here in case the intubation fails. And then both me and my partner would have on the appropriate PPE for this procedure. So after I have all my equipment set up, I would tell my partner after the next breath to remove the OPA, which is inserted, which he's using to pre-oxygenate the patient. So after the next breath, remove the OPA. So OPA is removed. Position the head how you want it. Come in, verbalize the chords. There we go. In. So you insert, you inflate the balloon, remove the syringe, pull this out, have your partner attached to the BVM, have him breathe air. We would listen to epigastric sounds, and then you'd listen for lung sounds. You'd also have the patient attached to SpO2 and end tidal as other ways of confirming. I also verbalized that I saw the chords before I passed the tube, another confirmation that I'm in. So next you would grab your securing device, place it, come on to secure it, and then you secure it, and then you would continue breathing for your patient, one breath every 5 to 6 seconds. And then you would continue to monitor your end tidal SpO2 to maintain the airway and make sure the airway is still patent. And then if there's any secretions, mucus, anything like that in the tube, you would use suction, sterile technique to suction out the airway, and you wouldn't suction for any longer than 10 seconds at a time. And that is intubation.